Again, this is Roslyn. I'm the team lead for the State Program Office, the School-Based Health Center program. This is our spring coordinators meeting. So some logistics. The presentation will be posted on our website in the next week or two, and Melanie will send an email out to all the coordinators to let you know when that's posted. We also will have an evaluation, and we'll send that evaluation out in the next week. There are question periods during the webinar, like usual. And if you have questions at any point, you can write them into the question or the chat box, and we'll address those when we get to those question breaks. So here's our agenda. We have a pretty packed agenda today, so we're going to move through it. But again, if you have questions, please type them into the question box at any time. So I just want to start off the meeting today with just a couple minutes recognizing that right now there are many of us in our programs that are living with many uncertain times, and this may be due to policy changes or funding changes or funding uncertainties. And I know at the State Program Office, people recognizing that we're general fund is that we oftentimes are on the chopping block for funding cuts. And we've talked about that, and Jessica's going to talk a little bit about that today. But the uncertainty could be federal or local or state funding, and we know that there are communities and counties that have already experienced cuts. And I know that there are concerns that are from our community and from youth around some of the policy changes that are happening at the federal level also. So from the State Program Office, we just want to say thank you to everyone for all the work that you guys do for the lives of young people, because we know that it's not easy, and it's not easy right now. So thank you. I think a couple weeks back, I sent out an email regarding this statement, and this is just the first portion of it, that came from OHA. So the Oregon Health Authority continues to hear questions from local partners about the impact of the federal immigration policy and that impact on health services in Oregon. So this statement, and you can scroll to the next one too, it's just, I have it chunked out. It's intended to inform people in the community about the access to healthcare services and the information that OHA reports to the federal immigration officers. So this was shared with local public health, county health departments. We sent it out to our school-based health centers, so the coordinators and administrators should have received it. So please feel free to share that with your partners if you think that is helpful. And if someone needs the copy, the PDF copy, you can email our State Program Office, and I can send those out. So, shifting a little bit, so in the next year, our office is hoping to do a needs assessment to the field to determine the areas of technical assistance that's most needed by you guys in our school-based health centers. These are the categories that we hear from sites that they are struggling with, and these are the ones that we anticipate that sites are identifying as needing support. These are pretty big buckets, and so in order to provide the best technical assistance, it's helpful if we know really how to prioritize these buckets. So I have a poll question for the field to help us figure out which of these areas do you need the most support for the next 1 or 2 years. And I'm just going to briefly talk about the categories. Maybe go back one slide. Yeah. Sorry. Oh. So with utilization, what we're talking about is a decrease, really, and a decrease in utilization, and that could be for a variety of reasons. The funding, so funding, it could be that funding is unstable, that's unknown, or you are concerned about a decrease or a cut. And billing and reimbursement challenges that you're having, whether that's primary care, mental health, or dental. provider recruitment and retention, and that's both for primary care and mental health. And then clinical trainings and specific clinical trainings, or specifically working with specific populations that you may need help with. So again, I recognize that these are pretty big buckets. So when we launch the poll, if you could just help us think a little bit about what would you prioritize, which one would you prioritize as needing the most support for the next 1 or 2 years? And then we will dive into each of these a little more based on what you submit. So I'll just give it about 30 seconds for you guys to go through. I'll give 10 more seconds. Okay. Let's see what people said. So, not surprising, funding, billing and reimbursement, and utilization changes. So it's pretty helpful. I think this is helpful to us. Thank you. And this gives us an opportunity to kind of prioritize where we should kind of direct our technical assistance and for the needs assessment. So next, I'd like you to think about what else. What did we miss that's not in that bucket that you feel like is a pretty big priority for your school-based health center in the next 1 or 2 years that is not in that bucket? And if you could just write those into the comment box. So again, what are we missing that you feel like you need support with? What can the state program office help you guys with in the next year or 2 as a priority? And again, just write them into the comment box, and I will we'll take a look at those, and we can share those with the field. And you can feel free to write it in now, or you can write it in if it comes up to you. It comes up as we go along this afternoon.
Do you want me to say them?
No, we can let people write it, and we can think about it. Okay. Great. So we're going to talk a little bit about the staffing that's happening at the state program office and our budget updates. I'm going to turn it over to Jessica Duke.
Hi, everybody. So we have a few. I'm Jessica Duke. I manage adolescent and school health, which school-based health center program is part of. And we have a few staffing updates. You'll see a handful of vacants on the screen. So I believe that most of you should know by now that Stephanie Murray has left her position as of yesterday to go on a great traveling adventure for an indefinite amount of time. So we will miss Stephanie greatly, and we will be hopefully opening up her position for recruitment soon. We need to ask permission to do that because of this current state budget situation. All state agencies are in sort of a restricted recruitment environment right now. And we cannot fill positions for 60 days after vacancy. So the earliest we would have someone in Stephanie's position, the very earliest, would be mid-June, but we still need to work through the approval process first. So that's starting. And then we have two current recruitments open, one for the public health nurse, which was Lisa Stember's position. And we had that open. We had some candidates. We interviewed some candidates. We're likely going to reopen that position. So pretty critical position for us to have 2 public health nurses on our team. And so we're looking forward to reopening that and getting it filled as soon as possible. And then the vacant research analyst position, which is still a relatively new position for school-based health centers. Having 2 research analysts, which is really needed. We are in the middle of a recruitment and getting prepared to make an offer to one candidate. I'm hopeful that that candidate will be able to start in May. So that is where we are with staffing. Otherwise, all the same friendly faces are here for you. I wanted to give you a pretty brief funding update and let you know for the next biennium for 17-19, our crystal ball is not clear. We really aren't sure what's going to happen with general fund dollars that support school-based health centers. However, Public Health Division leadership has expressed hope that the SBHC budget will not be cut and we will be able to maintain current levels of support. Please don't read anything into that statement other than what it says. So there's nothing else to read in there other than our leadership is hopeful that we won't receive any cuts in the school-based health center budget. The legislature, as always, will make ultimate budget decisions. Because I've told you before, an SBHC budget cut is still in the Oregon Health Authority agency request budget, and it is still in the co-chair's budget when they presented a balanced budget. Oregon is still looking at a shortfall, so I cannot say with 100% certainty that we won't be cut. And if you have any concerns about what cuts might look like or any concerns at all, feel free to send an email to the program email, and we will kind of track those and share those concerns with leadership as we move forward. And that is really about all I can tell you about funding. I was really pleased when I had a discussion with PhD leadership, Public Health Division leadership, and they expressed that they didn't think it would be cut. So that is my hopeful bit of news. Better news, the biennium we're currently in, we were well funded for the 15-17 biennium and had some extra money to allot to centers. And so by now, everyone should have received a one-time award of $6,500 for each certified school-based health center in the county. The process started in February, but it was awarded to counties alphabetically. But by now, every county should have received that $6,500 additional funds for school-based health centers. There are no reporting requirements beyond putting in what you need to for the county revenue and expenditure report, and all funds must be spent by June 30th, 2017. There's no rollover whatsoever. And then these are the suggested activities for that additional $6,500 in funding. If you have any questions about an idea that you have that you don't think necessarily fits into anything on this list, feel free to reach out to us and we can walk you through that. But we really wanted these funds to be able to give you a little bit of extra capacity this biennium to do certain things that you're not able to do with your base funds, and then also just a reminder to keep your eye on the future that we might not have additional funds like this in the next biennium. So any questions? You can type them in and Melanie will let us know.
There's a question just for clarification that this is not the youth-friendly grant, correct?
Correct.
Correct.
Correct. That is separate grant funding. Any other questions?
Nope.
Great. So we'll move on to our mental health updates. So as Jessica said, Stephanie Murray, who was our mental health specialist, has left. And so for the grant during the next couple months, the grant coordination is going to be taken on by Kate O'Donnell. So Kate's going to give an update on where we are with the mental health expansion grant, which you've heard a good amount about already, and she'll tell you guys where we are now. And then we're going to hear from some of the school-based health centers in the field about some innovative models that they've been working on that the expansion dollars can be used for.
Great. Thanks, Rosalind. Hi, everyone. This is Kate O'Donnell. So before we get started on information about the grant application process, just a couple of things to take into consideration. This kind of goes along with what Jessica was just discussing, but so our current structure for the mental health expansion grant during the 2017 and 2019 biennium assumes that we will be getting the same amount of money that we received during the last biennium. As Jessica mentioned, we really don't have a 100% clear idea of what that amount will be. We're assuming it will be the same amount, but the final say really goes to the legislature. And so we may not have a final number of what the award amount will be until potentially as late as July when we get the final legislatively approved budget. So our plans for the mental health expansion grant application process for 2017-2019 is also contingent upon approval from the Conference of Local Health Officials. Both the Healthy Structures and the CLO executive committees will be presenting next week to both of these folks, and so we'll be asking for feedback from them, but we won't actually be able to go ahead with the current application process until we get those approvals. So this is all just to say that there may be some changes to the information that I'm sharing today, but we will keep you informed as those changes happen. So the first piece I'm going to talk about is the capacity grants. So these will be, the application for these will be released on April 21st, so that's next Friday. Applications will be due June 1st, and we again anticipate to release those funds in summer 2017. I think you will be pleased when you see the RFPs. It's not actually even an RFP. It's much, much shorter than in previous years. So in previous years, they were like 10, 15-page long applications. It is much more brief this time. And so the capacity grants will have two funding options. One will be funding formula funds, so you can apply for those. If you are currently a mental health expansion grantee from the 2015-2017 biennium, or if you are a planning grantee. So that's essentially just Madras High School if you receive planning funds in the 2015-2017 biennium. And then the second pot of funding is pooled funds, and those are available to all certified school-based health centers. So you must be certified by June 30th, 2017 to apply for those funds. The funds for both of these pots are mainly going to be used to support staff time for QMHPs. So in previous years we had different buckets for special projects like telemental health. Those are not available this time around. Next slide. So an overview of the funding formula funds. So as I mentioned, so each SBHC that is currently funded, so funded in the 2015-2017 biennium, will be able to apply for formula funds. Steph mentioned this, over the past several coordinators meetings. The funding formula was developed by a mental health advisory group, and there'll be more information about this in the actual application. But essentially, the formula works like this. So each SBHC who is currently funded for mental health capacity will receive $50,000 in mental health base funding during the 2017-2019 biennium. Then, on top of that, each SBHC is eligible for an additional $10,000 to $90,000 funds based on these two variables that are listed on the slide. So it was the previous year's free and reduced lunch rate for the student population at the SBHC host school, and then county mental health provider to population ratio. So these were the two criteria that were determined by the mental health advisory group. The total amount that your SBHC is able to apply for, if it's currently funded, is going to be outlined in a spreadsheet. So you'll get that with the application information, so you can see you can apply up to that total amount. Essentially, the way that it's been calculated is that school-based health centers who are currently awarded can't receive any more than 150% of their current award or less than 70% of their current award. Again, that's all outlined. You'll see it in the spreadsheet. There's a number for each school-based health center, so it should be somewhat clear. Slide. Oh, okay. So the next piece is the pooled funds. So any funds that are left over from the capacity or from the funding formula will go into the pool. And so as I said, any certified school-based health center can apply. So that includes school-based health centers that are not current grantees and aren't eligible to apply for that pooled or for that base funding. You can apply for pooled funding. You can also apply for formula or pooled funds if the formula money represents a loss to your school-based health center. So if you are getting less in the formula funds this year than you would be allocated during the next biennium, you can apply to the pooled funds to kind of make up that difference. The funding in the pooled funds is pretty flexible, and it can be used anywhere within the SBHC system as long as it's supporting capacity in the school-based health center. So if you want to apply for a different site, that's not currently being funded, you could apply for pooled funds. If you want to apply to support an innovative model for behavioral mental health care provision, you can apply for pooled funds for those. Essentially, we'll just ask you in the application to provide justification for why you need those additional dollars. You know, what's the need, what's the new model that you'll be looking at, and then how will you be working towards sustaining those the positions that those dollars will help fund. So the applications for pooled money shouldn't exceed $50,000 per SBHC for the biennium. So there is a cap on the amount that you can apply for the pooled funds. So that was the capacity piece. We will actually also be offering grants for youth advisory councils this year. They are limited to folks who are currently funded to do YAC projects during this current biennium. So the timeline for those will be the same. So you'll see an application come out for those on April 21st, which is next Friday. They'll be due June 1st, and then we anticipate releasing the funds sometime in 2017. So if you are a current YAC grantee, you'll get an application for continuation of the 2017-2019 grant. And then your funding will be essentially, you'll be eligible to apply for the same amount that you're currently being funded. So again, just disclaimer, we are not 100% sure what the amount of funding that we'll have will be, so it's possible that the total amount that we are able to award will be less than we anticipate. It's also totally possible that the total amount we can award will be more than we anticipate right now. It's also possible that the Coalition of Local Health Officials will not approve the funding formula, and so we'll have to kind of go back and figure out how we want to allocate the funding. So this could all change, but regardless, keep an eye out next Friday or at the end of next week, and we should have more information about at least what the application and formula process will look like. Any questions?
So this is Roslyn. It's a lot of information that Kate shared, and I think we've been talking about it a lot, but the funding formula definitely is not easy in the sense of easily digestible. I think the idea is that it does make it easier for you at the site level to have some predictability in how much money you will get at a minimum and what you're eligible to get at a maximum too. And for us, it's a little bit easier in the sense that there is some funding formula built into it. So if you have additional questions, obviously once the grant goes out, you can contact Kate or anyone on the state program office. I can lead you to Kate or myself for more questions. Great. So now I'm going to turn it over to Kristen Case, who's a nurse practitioner for Multnomah County, and they're going to talk a little bit about their behavioral health model that they've been doing with using some of the mental health expansion grant funds. Kristen, you there?
Yeah, can you see my screen?
We can.
Okay. So, hi everybody. So I'm Kristen Case. I'm the nurse practitioner manager, and I was also the nurse practitioner at one of our pilot sites. And I have Alex Bull here too, who's our program manager. So we are together in this. And what I was asked to do was just talk for a very few minutes around our behavioral health pilot. This is the money that we got from the state 2 years ago to create a pilot where we added a behavioral health provider, which is different than a mental health therapist, into 2 of our clinics. And so we're at the end of our 2-year grant. And I only have 7 minutes, and you have to know this is such a big subject. My colleague and I actually presented at the national level, and this is a 2-hour session. So we have 6 slides to cover today, but there's a lot I can talk about. So again, this came from the money from the state, and so we're at the end of year 2 of our behavioral health pilot. So this is, and I know I'm preaching to the choir here, but this is a slide we actually use nationally because I think it's really poignant, and I think it really speaks to why this is such an important position to have. So when this is some data across different sectors. One is looking at school-based health center reports, and I think this is national reports, that at least 1 50% of clients who came in had at least one mental health concern. And then the next thing to think about is when you look at adolescent injury, morbidity, and mortality, 70% is due to preventative behaviors. And then down to our level, when we looked at the sites where we were adding the pilots to, out of all of our clients we saw on the medical side, around 4% were seen by mental health therapists. So there was a lot of these kids that were seen by the medical provider, and we can do stuff, but we don't have the same level of expertise as a mental health or behavioral health therapist. So this really brought in the need to bring in a person that had a different model of care to work in our clinics. So this is a little bit busy, and I apologize. This actually came from SAMHSA. SAMHSA has a really good toolkit around co-located/integrated mental and behavioral health. So this is really looking at some of the differences between mental health and behavioral health. And the other thing I need to acknowledge is we have always had mental health in our clinic, and so we've added this person who's the behavioral health provider. They're actually trained the same. Our behavioral health provider last year was a PhD post-grad in psychology. This year she's an LCSW. So there's some real similar training, but they have a very different focus. So in looking at mental health, the treatment types, they're typically individual, family, therapy, pretty deep, some consultation, definitely crisis intervention though. Behavioral health is brief, more targeted, more skills-based, really more looking at functional impairment. They also do consultation and crisis intervention. And looking at the assessment from our mental health colleagues, we get a full mental health assessment. It's a 5- or 6-page report where it looks at the assessment, has a diagnosis, also has a service plan. And the behavioral health person will go through the differential diagnosis and screenings, looking at functional impairment, also an initial assessment, so I have a kid who might need to go on meds, and I'm just trying to figure out if there's some comorbidities. I can send this kid to the behavioral health person. Issues addressed, it's kind of a spectrum. A lot of our kids are actually starting with behavioral health, and they are kind of gatekeepers. They have a lot more access, and so then they're helping us to triage the kids into mental health because we have a lot fewer slots for mental health. But really, a youth who's going to be really a good candidate for our mental health is, first of all, a kid who's engaged in care. So I think there's really a disconnect between kids that we know need mental health, but they or the family are not engaged. So the behavioral health person is assessing for engagement. And then those kids with moderate to severe, multiple problems, chronic, definitely kids who have had trauma, which is a lot of kids, and are really open to doing that trauma work because it's really hard work. We like to get over to the mental health person. Versus behavioral health, they're really focusing on skills on a single concern: sleep, behavioral change around obesity, mild to moderate anxiety, stress, relationship stuff, parenting issues. So frequently we can start with behavioral health, and then they help kind of assess on it. A big difference for at least our program, and every program is different, is insurance. Our mental health therapists, because of their funding and how they can get reimbursement, can only see OHP and no insurance. And that was part of the beauty of behavioral health, is they see all of our kids. Kids with private insurance, kids with Kaiser, no matter what their insurance, there was no barrier to getting in. So that was huge for us. Length of treatment, frequently the mental health person is 3 months up to a year. Behavioral health is pretty much limited to a few focused visits, and it depends on where the kid is and where they, how much work they want to do on it. But it's much more time limited. Session lengths, and this talks about, this also talks about the accessibility. For the mental health person, they're usually, it says 30 to 120 minutes. Typically, they're hour-long appointments. Versus our behavioral health provider, she's 15 to 30 minutes. So the number of patients our behavioral health person sees is very different per day than our mental health person. And then the other really big deal is our same-day access. Most of our mental health is pre-scheduled, and behavioral health, we at least have 50% of our slots that are same day. So a kid that's in crisis right now, or crisis in their world, maybe not in our world, like they're stressed or they didn't do well in an exam or they have a panic attack, they can be seen same day with behavioral health, and they're really ready for that change versus me having a conversation, the kid is ready, but then, oh, well, you can't see the mental health person for a couple weeks. So that access issue has been huge for us. So just a little bit of this is overlap from what I just saw, but the behavioral health person is really integrated into our team, and that's one of our big differences. And you look at our metrics that we have to monitor with the state and with our insurance companies, with our CCOs, the behavioral health person is a part of that work as far as meeting the metrics. She or he can do experts. They review our health assessments because, as you know, most of our health assessments set the psychosocial metrics. So any kid that has anything positive on their health assessment, and Joanne is the person I'm working with, I could just send her into the room, and they can really follow up and do a brief intervention and set up a plan for those positive screenings for depression, substance use. They do school coordination, also really brief intervention around stress, anxiety, and then they do our suicide risk follow-up. And then along the bottom are some of the squares that really highlight some of the real value we see in it with our team. It's the same chart. We are EPIC. She's on EPIC too. Our mental health person is in a different electronic medical record, which just creates a lot of workarounds for integration. Same-day access, same as me as the nurse practitioner. We have a similar goal of population health. All of our clients are Joanne's clients versus a mental health person that may have a caseload. We have the same metrics, and we're in the same room, so we can talk really frequently. So then, again, goes back to who do we refer to, and really frequently when our mental health person gets really backed up, we actually start with behavioral health, and they become that triage person into care, and they help the mental health person make sure that they're seeing the right clients with their really limited access. Because the other thing I want to highlight is their work is really important. It's a synergy that happens. Behavioral health is different than mental health. There is an overlap at times, but we need really both, because a behavioral health person just can't do the long-term work. Her schedule is not built for it. Her role is not built for it. And definitely that trauma work is really better with a mental health person. And so really the behavioral health person is kind of the catch-all for everything else. So this is just a nice, for me, kind of a capturing of what I see as the difference. Mental health does this really great job of going deep with one fish. They spend a lot of time with that person. They can see a lot less people because they go so deep. And behavioral health for us has been more of a fishing net. They can capture a lot more of our kids and do more of a brief intervention and then triage from there. Fairly undone. But that's kind of what I wanted to say in this brief amount of time. Do you have anything to add, Alex? No, I think you did a great job. Thank you. And it's been a great model. So next steps, really quick, what we're talking about is sustainability. We this year have had somebody that's really, her productivity has been really high. She's been working on billing and finding those billable codes. So we're getting reports back that we're really actually finally starting to see some money coming back. So we're really working on sustainability because we'd like to expand it. We also have a third-year student that's coming in who's a post-master's who will be doing some work in two of our other clinics. So those are our next steps. That's it.
Great. Thank you, Kristen and Alex. Does anyone have any questions for Kristen? So if you have any questions, you can feel free to type them into the chat box. We'll spend about a minute before we move on to Benton County's sharing with us also. So we have one question. Melanie, you want to read?
Yeah. So the first question is, so one provider could not do both types of visits?
You know, that's a really good question. Go ahead.
And then there's a follow-up to that. Could one provider do a half day of mental health and then a half day of behavioral health?
You know, that's a really good question. And since I'm not in that role, I'm a medical provider, I will say I went into this, I've been seeing this vision and I didn't have a name for it for a long time, but I have seen where there's been models where they've tried to do that, and I'm always told this is really difficult, it's difficult work, I don't think we can do it, but I don't think I can answer that, because that was always my dream with limited resources, to be able to do both jobs. I do know that the brief intervention is a different skill set, so people really need to be able to flex between those two different types of skills. And that electronic chart issue too, so like flipping in, the other thing I heard is we're in EPIC for behavioral health and then we're in Evolve for mental health. So that would be my dream, but I have not actually seen it actually work.
Okay.
Or really take that on.
Great. So the next question is, how many patients does your behavioral health provider see each day?
She is averaging 7.9, so close to 8. And what happens with our mental health person, she feels that she has a higher no-show rate because they're booked out so far out. But the other thing that we don't see in that 8 a day is she does a lot for me. She does a lot of our phone calling. She's coordinating with schools. She's doing telephone visits now where she's calling clients. And so some of that data is not being included in. She's really an integrated part of our team. So she's doing a lot more behind the scenes work that she's actually not getting credit for with her visits that we just kind of hand to her now.
Great. We're going to, Kristen, have one more question, and then we'll move on to Benton County.
Are students ever seen by both mental health providers and behavioral health providers? If yes, how often does that happen?
You know, we actually have had that occasionally where I'm thinking like we had a client who was needing some trauma work and was struggling with sleep, and so was seeing the mental health person for trauma, and then was getting some really specific sleep hygiene from the behavioral health person. So because they're dealing with like one functionality, they might take on one symptom and work on that, like for example, sleep. So it doesn't happen very often, but they also, it's been a growing for us because we have both on especially mental health, really, that really understanding some of the differences in how we can augment each other. So we've had lots of conversations with behavioral health and mental health. Where does this kid go? Where do they land? And what's my work and what's your work? Or if they're not willing to engage mental health, we'll actually refer back to behavioral health just as a part of our team to support. So there's a lot of flexibility. You need flexible people in both of these roles. So that's the other thing, is there shouldn't be any turf battles, or then it's not going to work because there is an overlap that can happen.
Great, Kristen, thank you. So if anyone has any questions for Kristen, you can contact us and we can definitely put you in touch with her also, Multnomah County. So I'm going to turn it over to Benton County. We have Lori Diaz, who's the site coordinator at the Monroe School-Based Health Center, and then Linda, who's the behaviorist at Lincoln Health Center. So it's great to have them both. So I think, Lori, you're going to go first. I think you're muted, Melanie?
Yeah, Lori, you need to unmute yourself from your end. Okay.
Okay, can you hear me now?
Yeah. Great.
Okay. All right, so I'm Lori Diaz. I work between the Monroe School-Based Health Center and our Lincoln School-Based Health Center, site coordinator. I'm going to apologize if you have background noise. I am actually at another training and found a quiet spot in a park, so very sorry about that. So we're from Benton County. We have 2 school-based health centers. One is in South Corvallis at Lincoln Elementary, and the other one is in the town of Monroe at the grade school. Our behaviorists that came on board 3 years ago joined a staff, I'm going to use the Lincoln model, of 2 full-time doctors, 2 MAs, a panel manager, front desk staff, RN care coordinator, a health navigator, and the school also has a health navigator. We serve the students of the schools as well as the community. We have a team-based approach to healthcare, and we have found group classes to be very beneficial to our patient outcomes and to the population as a whole. The groups are usually during the evening hours, during our expanded hours that we have at each site. Some of the types of groups that we have done are our behaviorist in Monroe held a girls group. She met with 3rd grade girls and 6th through 8th grade girls on a weekly basis. The group focused on interpersonal skills, self and group empowerment, and anti-bullying. And then we have also taken a preventative focus, providing cooking classes for families. And then they've had other cooking classes that are focused on diabetics. We've had 28-day challenges, and that's for all ages. It's not necessarily a weight loss program, but more of a challenge to the individual to increase the good and cut out something bad for them, like sugar, sodium, fat, to improve their overall health outcomes. We have also had a group with families to prevent childhood obesity. They met with the kids and the families, the patients of the And the patients were patients of the clinic, or they were also students of the school. And then in Monroe, our behaviorist and doctor have gone to school during health class, and they've led discussions with youth regarding healthy choices. When the behaviorist is not involved in the groups and it's during clinic hours, they're available for warm handoffs from our physicians and other staff. And then they also take calls from the schools as needed, as well as have a schedule already built in. And with that, I'm going to pass it over to Linda to explain the role a little bit more.
This is Linda. Can you hear me?
Yeah, we can hear you.
Oh, okay. Thank you. I'm the behaviorist based at Lincoln Health Center. I've been there 3 years. Like Lori mentioned, I have 3 providers at my clinic, one of whom is a pediatrician, and we have 2 nurses, 2 MAs, 1 panel manager, and 1 front desk, 1 health navigator, and 1 pharmacist. We do not have a co-located mental health therapist. I just wanted to add that I was intrigued by the nurse practitioner's model, but we don't have a co-located mental health therapist. I do refer to over to our main county building for mental health therapy, as well as to our community providers. I work primarily, when it comes to children and adolescents, my referrals come primarily from the pediatrician in our clinic, and she refers patients who are struggling with anxiety, often related to school. She refers families who are experiencing multiple stressors. She refers patients who are presenting with symptoms of ADHD, autism. And my job is to screen, do brief interventions, and then coordinate additional needed services. One of the challenges is connecting children with specialty mental health. Often the agencies are full, or they have a waiting list, at which point I will continue to see them and meet with them until we can get them in. Our school, Lincoln Elementary School, has, I had been doing services in the school, and they received additional funding and are now contracting with a community mental health agency, and those counselors come into the school. The school also has a counselor and has a behavior support person, and then they have a health navigator from Benton County who does a multitude of things, which I just want to mention because I'm often amazed at how many things she addresses in the school. But she meets with students and helps facilitate the referrals to specialty mental health. She helps connect families with insurance, transportation, basic needs like food, gas, laundry, shelter, housing, toiletry, clothing. She provides some referrals for families struggling with immigration concerns. She is able to provide transportation to medical appointments. There is funding for students who qualify under the homelessness program. She connects children and families to after-school programs, to CARDVA, our Center for Domestic Violence, I think that's it, but I'm always impressed with what she's able to do. So in our situation, I provide behavioral health support within the clinic, and because the school receives some additional funding, they have connection to mental health, behavioral support, and case management needs separate from the clinic.
Great, Linda. Thank you, Lori and Linda, for sharing your model. I think the idea is to have, Multnomah County and Benton County share some of the innovative work that's happening in school-based health centers to meet the need. We know that there is a high need for mental health services, and there is, we know that there's only so much capacity out there. So it's great to hear that communities are trying to work through some of the capacity issues. Are there any questions for Lori or Linda? Okay. No. Oh, let's see.
Do you use multiple levels of service?
And could we clarify that question?
Sheena, can you provide a little more information for that question? We'll give her a second.
For billing. Multiple levels of service for billing.
Well, I mean, as a behaviorist, I have access to 6 billing codes, assessment, individual, session with family, session with family and patient, group, and I apologize, the 6th one fails me right now, but those are the billing codes that I'm unable to bill under.
Great.
Okay.
Great. Sheena said thanks.
And then we have another question. How many patients do you see each day?
I make contact on average with 8 patients a day. I would say probably 5 of those are scheduled appointments. 4 of those are scheduled appointments, and 3 are warm handoffs where a provider will ask me to come in, introduce myself and the role to the patient. And then I'm usually doing some case management, making phone calls, doing outreach. So probably 8 to 9 contacts a day.
Great. Okay, so if anyone has any additional questions for Laura or Linda, you can feel free to contact them directly. Their contact information is in the presentation, or you can contact us and we can get you in touch. Thank you. So we'll move on. So we have some certification updates, and I will turn it over to Karen Vian, our public health nurse.
Hi, this is Karen. It should not be a surprise at all that the certification standards have been being updated over the last year or so, and they're ready to be published and be used in the field. Sites are going to be held to these new certification standards beginning July 1st of this year. You can also find them online right now on our website. And if you have any questions about them, you can email me or call me. My contact info is there. The certification review tool that I use when I do site reviews, I am currently working on revamping that to match the new certification standards, and it will be posted online in July.
Okay. Hi, everyone. This is Melanie. I just wanted to let you guys know that we're in the process of printing the certification standards that Karen said that we can find on our website, and they should be arriving to you all in late April, so in the next couple of weeks. And just to let you know who they're going to, so there's no confusion if one shows up at your office, we're sending 10 copies to each school-based health center, 1 copy to each coordinator, 1 copy to each administrator, and then 1 copy to each health department primary contact. And these addresses are all based off of y'all's operational profiles. So please keep in mind that they're coming and that's where we got the address. And then I also wanted to let you know that we're going to be doing 1 mailing with 2 items in it in the next couple of months. The first item is your new biennium plaque sticker for the 17-19 biennium, and you'll see a picture on the right side there. It's going to come in a standard letter-sized envelope, and it'll be in a little plastic bag that's attached to it because it's a very small item, so we don't want you to lose it. And then just as a reminder, those stickers are supposed to go on those fun little certification plaques that we sent you, you'll see some pictures at the bottom of the slide of the old plaque and the new plaque. We updated our plaque a couple years ago. Some of you still have the old plaque, and the idea is for you to fill up that plaque with your biennium stickers, and then once it's full, you let us know and we'll send you a new plaque. And new sites that are newly certified since we did the old plaque, did the new plaque, get the new plaque. I said plaque about 20 times. So if you have any questions about that, let us know. So in that mailing, you're going to get the plaque sticker as well as an updated table of contents for your certification binders that Karen reviews when she comes to do her site visits, and it has the policies and procedures. So we're going to send you a new table of contents that reflects the new standards.
Great. Looks like we have some quick updates. So any questions regarding those certification updates?
So the first question is, so the new certification standards on the web page, the final version, are they ready to start using?
Not yet. We just finished the final PDF copy of the beautiful standards, so it's not up on the website, but the Word version is on the website. So that is exactly the same as the pretty copy. So if you want to...
So just to be clear, the content on the one on the website is the same as the content that will be in the pretty one that will go out. Yeah.
And to add even another layer to that, I will be posting the pretty PDF of the standards within the next week or two. So the pretty PDF will be on the website soon, and you'll be getting a hard copy of the pretty designed version in the mail in a couple of weeks.
Great.
I think that's it.
Any other questions?
Okay.
Okay, on to our data update.
Hi everyone, this is Sarah Nipper. I'm going to give just a couple of updates related to data and billing. So the first thing I wanted to just mention really quickly is that the National School-Based Health Alliance, every 3 years they do a national census of all school-based health centers. They are getting ready to be rolling out their new census. They're going to be contacting school-based health centers in early May. And if you have participated in the census before, I will tell you that this one is so much shorter than anyone they've done before. They've cut it at least in half, if not more. So it's going to be a lot easier to fill out, especially for those of you with multiple SBHCs. They really cut down the burden on having to fill out multiple things. There's still a few pieces that you'll need to do for each of your sites, but for the most part, it's going to be a lot simpler of a process. So it is a requirement of our state program office funding as part of our program element through the county contracts that all of our school-based health centers complete the national census. And then, once those emails go out, we'll probably be just reminding you all as well. But I wanted to just give you a heads up about that. So just be on the lookout for that. And then I wanted to spend a few minutes talking about a memo that we sent out to all the coordinators in March on access and billing policies. And I believe it was it's in the handouts on the webinar, right?
Yeah.
So,
on the right side.
yeah, so if you go to the right side, you should see a PDF called Billing and Access to Care, or March 2017. Billing and access memo. So we sent this out in March, and I just wanted to spend a couple minutes just reviewing it and see if folks had any questions. So we at the State Program Office had received some comments and questions about what our expectations were with respect to billing policies and access to care policies within the site, kind of going beyond within the certification standards. So what about, restricting utilization or access depending on folks' PCP, or what about policies related to sending kids to collections, or what the policies as far as, if kids don't pay or if parents don't pay. So we wanted to draft something to send out to try and give a little bit more clarity to our position. So this kind of goes above and beyond what's in certification standards, which means that you know, this is kind of our office policy as far as what we would really like to see. Much of it is not actually in certification, but it's something that we're going to be looking for and would like to have conversations with you about if this is causing problems for you. But essentially, the memo, you know, we kind of affirm what's in the certification standards, which is that students should not be denied access to services based on insurance status or ability to pay, that sites are required to bill Medicaid and maximize other billing, and in our new certification standards, you know, that billing requirement is increased a little bit in the sense that every provider who is eligible needs to be billing Medicaid. We also recognize that depending on who your medical sponsor is, if you have FQHC or RHC status, you may be subject to certain rules around sliding scale or how your fee policies work, and then also depending on your insurance contracts, you may have contracts that specify how you set your billing policies. But having said all of that, the point of this is to just state our expectations, which is that we really want to make sure that the services that you provide as a school-based health center are available to everybody, regardless of, you know, their ability to pay, their assigned PCP, whether they need confidential services or not, who their insurer is, you know, number of visits. And, you know, we understand that a very important part of what you do involves referrals and warm handoffs. And so it may be appropriate and the best option sometimes to make sure that your student is connected after a certain number of visits to a resource in the community that can really support the needs that they have. And we're not saying that that's not okay, because that's completely part of the model. But what we want to avoid happening is for someone to come into a center and, you know, to sort of say, well, you know, if you are assigned to, you know, PCP X, we can't see you, so we're going to refer you over there because that's our policy. So that's the kind of thing that we really don't want to be seeing, and we know this gets really, really tricky. We also know that, you know, that a lot of what you all do is you provide all the services that kids need, and sometimes that gets hard from a sustainability standpoint, and it also gets hard from a capacity standpoint, particularly when we're talking about behavioral health and mental health. But this is kind of our expectations, and I'm more than happy to talk to folks if they have concerns or questions about this. And then the second part of the memo talked about policies that we'd like to see available to clients, because I know these things get very confusing, but we'd like to make sure that to the extent possible, families and clients understand exactly what the SBHC or the medical sponsored policies are. So, for example, what's your policy on fee schedules? How does someone request confidential services? Just to make that as clear as possible. What happens if someone doesn't have an account that's paid? You know, if they're going to be sent to collections, or if there's another process that you all have. And then I think almost most importantly is if someone has a question on billing or how confidential services are handled, who can they contact? You know, is there a person that's designated? Is there an email address? Do they just talk to the person at the front desk? And I think that, you know, our intent here is just to try and encourage people to be as clear as possible and as transparent as possible, understanding that you may not, some of these things are really tricky and you may not have them all figured out, but being as transparent as you can with clients is really ideal. So again, I know some of this gets hard, especially when it comes to mental health and behavioral health, where there's an incredible need and the capacity sometimes doesn't meet it. And so we know, like in some sites, there are limits on services and the number of visits that you know a kid can have before they get referred out. And so we recognize that as the reality. But we really just want to encourage. We want to encourage sites to not have kind of unnecessary restrictions or arbitrary rules on limiting services and to just be as transparent as possible with their policies. So again, I'm happy to answer any questions, or if you want to follow up with me offline, I'm happy to talk through that as well.
And it looks like we don't have any questions yet.
Great, we'll turn it over to Loretta for some KPM updates.
Hi everybody, so I'm going to briefly, I have quite a few slides, and I'm going to briefly talk through them, and the main thing I want you guys to know is I'm going to be sending out an email in the next couple of days summarizing the things that are here in the presentation. And what I want to remind folks when they get that email is to be sure they forward it on to anybody that needs to know about KPMs, data reporting, and that sort of thing. So the first slide here, in our winter coordinator meeting, we talked about changes that we were planning to make for the KPMs, and we had worked together as a team to come up with a list of items, and then we sent out a questionnaire, a survey with some questions, and we took into account your feedback. There was one thing that we decided not to make a change, and that was as a result of what you guys had to say. So I wanted to let you know that your voices were heard. But so quickly, some of the changes that will be effective starting July 1st, 2017, so any visits that happen from that day forward. We've updated just some procedure codes and diagnosis codes where it's appropriate. Some additional codes were added. ICD-9 codes, of course, were dropped. We changed some wording on our guidance documents, and those will also be sent in the email. I'm going to send all of the updated guidance documents, so I'm not going to spend a lot of time going through here. But like I said, there are a couple of things for how to exclude some clients so you guys don't get penalized and have your percentage compliance lower. Another thing to note is that for the optional key performance measure that you've chosen, you have to have a minimum of 20 clients that were eligible for that optional key performance measure. And I'm going to be sending out in my email a table actually listing all of the optional measures that you folks chose last biennium. And I'm also going to identify sites that are going to need to choose a different optional measure for this upcoming biennium. And obviously, feel free to contact me with questions about that, and we can talk offline. Another change for the KPMs is that we're making all of the benchmarks be the same, which is 60%. That was one of the things that we were trying to figure out, and we talked about having the percentages be different based on how you performed the previous year, but we decided for simplicity we're going to keep them all at 60%. And like I said, the guidance documents will be posted up onto the website, but there are some website changes that are going on, so we're trying to figure out the timing of that. And so this is where I just want to remind folks, depending on the primary age of clients that you're seeing at your school-based health center, that's going to impact the optional measure that makes sense for you to choose. And for ones that are primarily just see the elementary school population, really the only measure that's appropriate for you to choose is nutrition counseling. And so we've broken that down in this little table. This table's been out there before, but I just wanted to go ahead and put it up again. Again, this will also be, I think my email is going to be really long, but and then on the next slide, so every biennium, sites are required to go into our web-based operational profile and do a new selection for their optional measure. So even if you're choosing the same measure that you've been tracking for the past 2 years, you still have to go in and do a new entry. And you'll see on this slide, I've got a screenshot in here of what it will look like currently when you log into the operational profile, and you're going to press this little button that has a plus sign, a green plus sign, optional KPM, and this is where you're going to select for the 2017-19 biennium. All sites are required to do this by May 15th. If you have the exact same measure for all of your school-based health centers, you need to go into each school-based health center and do a different a selection for each one of those. I'll also include this link and a little screenshot in my email, but always don't hesitate to contact me. But our goal for having everybody to complete this is May 15th. It just helps us to keep track. And now, as a result of the new certification standards that are beginning July 1st of this year, there are some additional data variables that will be required. They're not required when you submit data on July 15th. They're only required on visits that begin July 1st, 2017. So the first time you won't have to report on these new data variables won't be until January 2018. Which I know it sounds like a long ways away, but of course you know from the data report perspective you need to start working sooner rather than later to get the different variables added in. So quickly, we're going to ask the patient Medicaid ID number be added when it's appropriate, the modifier code that's associated with any procedure code, provider name, and the National Provider Identifier number. And I've actually included a link. I did a little searching and included a link for folks, and I needed to learn about this a little bit more also. So if you've got questions about what the NPI number is or how to get it, go to this link. Obviously, contact our office. And as a note, the changes will be made in the Epic Ocean automated data extract. So this additional reporting is really for all of the sites that aren't on Epic through Ocean. And if you want to submit your this year's year-end report and include these variables, of course you can do that because early is great. All right, and then just wanted to list here all of our upcoming data deadlines. So again, the optional KPM selection needs to happen by May 15th. Everybody's satisfaction survey samples should all be completed by June 30th. And I pulled a report today, and I'm going to send an updated email out to all the folks that have completed their required surveys. So you'll be getting that in the next couple of days also from me. The year-end encounter data report is July 15th, like always. And then way down in October, October 1st is when your KPM chart audit needs to be submitted to our office. You'll be hearing a lot more about other deadlines for October 1st, but I just wanted to add that in there for a data deadline. Anybody have any questions? You can always just contact me via email or phone.
It looks like a question for exclusion in KPMs. Can 2 no-shows be 1 no-show plus no return phone call from the parent patient to reschedule after we've left a message to call us?
Yes, I would say so.
Okay, great. Any other questions? Okay. Feel free to add them into the box at any point. I'm going to move on though. Okay, so Laura, I was just mentioning the October 1st deadline. That's including the KPMs. That's actually the deadline to update your operational profiles with your financial information, with all of your operating stuff, staffing details, KPMs, all that stuff, and you'll hear more from us on that topic. But about operational profiles, I want to let you all know that we are updating our platform. It'll still function the same. It's just going to be pretty with color and not be so rudimentary looking. So you will be using our current system until the middle of July, and then we will be shut down for about a week, so no one will have access to their operational profiles from July 10th through 14th, and we'll send out more information about this. And then after the 14th, we'll be sending out a new link for you all to access your operational profiles starting that following week. Your login information will be the same. You'll just be using a new link. So you'll have to update all of those web browser saves and all that stuff, and we'll be updating our website with a new link. So I'm sure there'll be some growing pains with remembering the new link versus the old link, but we'll help you out. And so keep an eye out for that. For our emails more towards the summer, we'll be updating you further on that. And just as a little sneak peek, this is what it's going to look like. It basically looks the same, but it's just a little prettier, and I'm hoping to improve some of the functionality. But you'll see that everything pretty much looks like it does on the current one. And also, just to let you know, we have, in order to get some more information in line with the new certification standards version 4, we've added a new tab for services, which basically goes through the comprehensive pediatric healthcare services that we have listed in the standards. And for all of the services that we don't require to be done on site, that we require by referral, we've listed them out here so that if you actually do them on site, even though it's not required, we want to start tracking who's doing stuff on site and who's doing it by referral. So it's the only ones listed are the ones that we only require by referral. And then also, just to give a heads up on another change we're going to be making on the financial and annual revenue area in your entries, we're going to be splitting the third-party billing into mental health and physical health revenue. So instead of those being bucketed into one answer, we're not going to require you to do the math to add them, and we're going to have them in 2 separate categories so that we can look at them separately and help us dive a little bit deeper into some of that information. And then also, just to let you know, we will be doing an operational profile training in the summer. Plus, we'll be updating our user's manual with all of the pretty new slides and information on how to use the new system. So keep an eye out for the save the date on that. Any questions? Oh, we just have an awesome exclamation point. Okay. Yeah, let me know if you have any other questions. Feel free to send them by email.
Great. And then one last, you can go next slide. So one last somewhat data-related update. So our state program office is prioritizing supporting the sites to increase the provision of reproductive health comprehensive reproductive health services on site. And in order to do that, we need to better understand what's happening. So I'll let Kate talk a little bit about a reproductive health assessment we'll be doing.
Hi everyone, this is Kate again. So as Rosalind said, this is a priority area for our program, and we know it's a priority area for the site. We get a lot of phone calls from you all with questions about this and wanting to know what other folks are doing on this topic and wanting to know how you can potentially make changes to some of the policies at your site level. So as Rosalind said, this will be a survey that will go out to the field hopefully next week, and it will just provide a really brief snapshot in time of the current level of reproductive health services that are being provided at our centers, what are some of the successes around reproductive health services, and what are some of the challenges that people are experiencing. The idea is that we're going to take this information and use it to develop a plan to better support you all around these topics. So we do get a lot of requests for support. We want to know kind of where the main issues are, and so over the next year or 2 years, this is going to be something that we really want to focus on to provide better support for you all. So keep an eye out. It should come to your email from me, and we're asking folks to respond by mid-May because we know that the school year is rapidly coming to an end, and so want to be able to get this out to you before that happens. Any questions?
Oh, I do have a question. Is there any guidance from the state on the mandatory reporting in regards to reporting minors having sex with each other?
No, there's no particular guidance on that. Our recommendation is always when you're in that specific situation that you need to connect with your local legal counsel. And I recognize, this is Jessica speaking, I recognize that that is probably not the full answer that you are looking for, but that is the answer that we can provide.
Okay. Any other questions? Okay.
Great. So as you all are probably aware, we've been really trying to support the youth-friendly piece of our school-based health centers and supporting YACs. And in our coordinators meeting, we're trying to highlight some of the YAC or the Youth Advisory Council work that's happening in the field. So Tricia, who's the provider at the Lane County 4J School District School-Based Health Centers, has graciously agreed to present on some of the work that their YAC is doing. So Tricia, you there?
I am here. Can you see my screen?
Yes.
Perfect. Thank you for inviting me to speak today. So I'm going to talk about our advisory councils. We just started new ones at 2 of our school-based health center sites. I'm the nurse practitioner in them both down here in Eugene. They've been around for a long time. One of our sites has been here for 31 years this month, which is pretty exciting. And they've had these councils before, but that was before my time, and I would hear stories and see pictures and evidence of it around our health center and thought, oh, that's such a great idea. But we needed to get our ducks in a row, so to speak, to be able to reinstate it. And for us, that meant getting some funding, so we were able to apply and get that youth-friendly grant, which helped us. And so we tasked our advisory councils with 2 roles, an advisory one and an advocacy one, and that's what I'm going to be talking about today. So as advisors, we started with just an informal asking our young people about our space and how to be more youth-friendly. At one of our sites, we got rid of an old weathered couch that a lot of people loved but really was falling apart and put them into individual chairs. About 1/3 of my patients are young, elementary and middle school students, but 2/3 are high schoolers. And, you know, I had Legos and coloring books and crayons and things like that in my waiting room, but we really didn't have anything to do for our teens. And so we added some adult coloring books that are so popular right now with colored pencils and even a sharpener, which we were told by them that you need to have to be able to get those little spaces, and some Rubik's Cubes and other kinds of manipulatives. And what came out of that was more than what we thought. So we knew that, you know, they would have something to do while they were waiting the few minutes for their appointment to start, but also some of our kids that are seeing either myself or our mental health therapists for anxiety in particular, we're starting to use that as part of their school plan. So when they are triggered in the classroom, for example, part of their plan is to be able to step out of the classroom, and they used to maybe take a walk or listen to some music or go to the bathroom or get a drink of water and come back. So now some of them are coming to our waiting room and saying hello to our health assistant and sitting down and doing, you know, coloring for about 5 minutes just to regroup and then get back into their classrooms. So we're finding some added benefits to that. For advocacy, I'm going to break it down into a couple of things. One is school, and we asked our young people to develop some peer education projects that they would implement within their high school among their peer students. And the other has to do with our community, which we broke down into state advocacy and county. So we have 2 sites and therefore 2 approaches, and they're very different from each other. So I wanted to kind of spend a little time talking about that. So at one site, we have 11 students. They're mostly sophomores, which you can imagine is exciting for future youth advisory councils that they're young and hopefully will stay with us. At the other one, we had 8 students, 4 were seniors and 4 were juniors. So at my North Eugene site, we recruited through school staff recommendations. So teachers, counselors, myself, we recommended some students to consider applying, and then they completed an application and came in for an interview. We incentivized them with an extracurricular activity that they can put on their resume or opportunities for their required volunteer hours for school. And a majority ended up being students who have used our services, so that was pretty exciting for us. On the other site, we have a health occupations class. And so we went into the classroom and recruited from there, and they were incentivized just with class credit. They have a class report they have to do each year, and this could be a project they could use to do that. But unfortunately, none of them were active clients of our school-based health center. So at the one, we had a little bit more involved staff members. Both sites had the school nurse involved, which was a great partnership for our school-based health center and school to have. And then both got some ancillary support from our clinic health assistant, things like reminding students of meetings, ordering food, that kind of thing. But our North Eugene site also had an added consultant, which actually used to be the school nurse in past years who had some experience working with an advisory council, and we used the grant funds to help pay her. And they did their meetings after school. They had their initial one on a no school day, and all 11 kids came, which was pretty cool. And then they've had after school meetings that are about an hour, hour and a half. What that allowed for was some bonding activities, some deep discussions around healthcare topics, some advocacy training. They did a lot of their workload during, or they're doing them during those meetings, and we provided snacks. The other site did more quick lunch meetings. So lunch is a half an hour. They would come, we'd provide lunch with pizza and salad, and it was really sort of task focused. Where is everyone at in terms of their education project? And then we would split up the work, they would go, and then the next meeting we would talk about what everyone did. And we tried to pair them up with one senior and one junior to sort of follow the recommendations of the class. So North Eugene came up with one broad health topic, and that was healthy relationships. And their plan is developing an interactive Instagram initiative. And so they've set it up, and they've been videoing and taking pictures of different aspects of what a healthy relationship would look like, not just romantic, but with parents, with family, with teachers, with friends, those kinds of things. And they're going to be posting and hoping to get some interaction from the school community. So they've been doing some outreach and having a table during the lunch break, handing out lollipops and saying, you know, join our Instagram or follow us on Instagram is the terminology. And then the other site did a survey of the students at their high school. They were actually able to get almost 500 surveys back, which was pretty exciting. And they broke it down into 4 health topics that were chosen by students. So healthcare access, which was great for us as a school-based health center because we're one access point for students. Mental health, pregnancy prevention, and sleep hygiene were the others. So in North Eugene, with the Instagram initiative, so that's all happening right now. We see benefits being that it's technology relevant, which is important for young people, and interactive. But challenges, as you can imagine, we asked our Youth Advisory Council members to bring in permission slips from their parents saying, like, we understand our kids are being involved in a social media project, and they're also interviewing fellow students. We asked those students to bring in permission slips too. But of course, once they're posting, anyone can follow and put something on there too. So that's going to need to be monitored because obviously we want positive things being posted within our healthy relationships discussion. And some of our staff adults are not as technology savvy, so this could be a challenge in this project. And then at Churchill, what was great was that they really listened to what the students responded in their survey. The benefits of how they're running it is that it's conducive to the YAC member school program requirements. So we've got buy-in from them. They're going to be graded on this by their teacher. So it's very youth-driven. They're doing all the research. So it means less school adult participation in this. They're kind of a broader guiding. And then they're doing some more topics, so we're kind of interested to see how that works. They're planning on putting posters around the school, flyers. They're going to be making on the intercom, making announcements about some of these health topics. They're hoping to go into some freshman health classrooms to talk about them as well. And then the challenge is that it's a little less interactive with the student population as opposed to what North is doing. So community advocacy, I'm going to talk a little bit about state first. We were able to take 6 students up to the Awareness Day at the state capitol, hosted by the Oregon School-Based Health Alliance, which was a really positive experience. It was new for myself and Claire, who went up with me with these kiddos. Only 4 kids are pictured here because we didn't have permission from parents to picture the other 2, but we were able to participate in the morning with some of the preparation activities they had, and then we met with 5 legislators from our area. And so it was pretty exciting, and they were nervous at first about what to say, and I had tried to prep them ahead of time. I said, you can tell your story if you want. You can just talk about school-based health centers and what you think the value is for young people your age, or you can ask questions, because that's another important thing as well. These are your legislators, and they want to hear what your concerns are around healthcare. So in the beginning, they were nervous, but by the end, I was just so impressed with how their confidence grew with each one, and getting a ton of talk. So some really did speak from the heart, and we got a lot of positive feedback from the legislators. One, pictured on the right, Senator Manning actually came about a week and a half ago, came to one of our sites and visited. So he was able to meet with some of the YAC members who weren't able to go to Salem, so hear some of their stories and get some of their questions, and then talk to our school principal about what the value of school-based health centers was and the services we provide. So it was kind of a great overall experience. And then our local community, Lane County, that's something a little more down the road that we're working on. So we haven't done anything yet, but we've got some ideas. And one is our Lane County Public Health Advisory Committee, which meets monthly, and they are open to having us bring a student there where they can hear public health topics being discussed and even participate if they feel comfortable. And finally, our school-based health centers are looking towards getting a medical sponsor, and we're hoping that they'll be involved with communication once that happens. Some more next steps. This year, another idea that came up when we were thinking about being youth-friendly was a mindfulness app. So we have our iPads from the state program office that we do our surveys off of. And we were hoping, not all of our students have access to devices to be able to do this, but I've been hearing some positive things about those that are using mindfulness apps. And we thought, when they come in and they're coloring, they're playing with Rubik's Cube as part of their anxiety, maybe we could have them be doing a mindfulness activity. This could also be beneficial prior to a mental health appointment or maybe even after a mental health appointment. The challenge of providing mental health care in a school-based setting is that they get into some deep, heavy things and then we send them back to class. And that can be a challenge, but maybe some kind of quick activity that they can do in the waiting room, might help foster that. So that's on our to-do list. And then next year we need to think about how we can sustain our program. We won't have that funding anymore. So thinking about alternative funding sources for staffing, snacks, transportation, and then recruiting and sustaining current members. So I'm happy that a lot of our members are on the younger side, and I hope that they've had good experiences with this and consider coming back to us next year. So I'm ready to answer any questions of anyone who has it. I'm hoping that I've given you guys a couple of different approaches, one that's much more involved with more staffing and more time spent, and then one that's a little less involved that still gets a positive result from having Youth Advisory Council, in a place where there isn't as much time or resources.
Tricia, this is Kate. Thanks for your presentation. That was really fantastic, and you guys have done so much awesome work this year with your Youth Advisory Council. I was wondering if folks were interested in following your Instagram campaign or seeing some of the things that the youth have posted. How could we do that?
Yes, so the account is active right now, so you can even follow it as of now, and it is lowercase NEHS_TAC. So that's North Eugene High School, so NEHS_TAC.
Awesome, thank you.
All right, so we do have a couple questions. So the first one is, what is the regularity, with what regularity did the YACs meet? Weekly, monthly, etc.?
So we started them, we were recruiting in October going into November. By December we had identified everyone and had our first meetings. So really things got going more in January when we came back from winter break. And at one site they were meeting, so at Churchill they were meeting every other week during lunch to just identify the tasks, go out and do them, and come back and report. And now we've actually slowed down to once a month because they're putting together all their research and getting ready to get active. At the other site, they are meeting, I'm pausing a little bit because they met pretty frequently in the beginning, once a week back in January, and then they have switched to every other week now. But we anticipate that we might increase that a little bit as the Instagram account gets going and we have responses, that we may start doing some more quick lunch check-ins just to kind of review what's being posted and how we should respond as a team.
Great. So another question, what was the average time commitment weekly or daily for the staff?
And so that differed at each site. So at the North Eugene, the one that was a little more intensive, like I said, that first meeting was 3 hours. So we were using grant money to pay, these people to come in to do this outside stuff. They did And then they were doing 1.5-hour meetings after school, so that was also extra contract time, which we used in the grant. Our other site was just meeting with the students, and so they stayed during that whole meeting, those adults, 2 adults. It was the school nurse and the consultant. And then at our Churchill site, it was the school nurse who just met during the half-hour lunch hour every other week.
Great. It looks like we don't have any more questions. I'm going to change us back over here.
Tricia, this is
Thank you.
Rosalind. I just had one question. So, and you briefly touched on this, was that, you know, with the grant funding ending, you guys are exploring other ways to keep it sustainable. What do you think the likelihood of your YACs sustaining if you're unable to get grant funding?
I actually feel pretty positive. Some of the activities we've done, like through the Oregon School-Based Health Alliance, they were able to offer some scholarship money to help with transportation when we went to Salem. So that was an asset for us. And I could see that continuing on in the future. And we won't have that consultant, so I don't know how much we'd be able to do those after school long, involved 1.5 to 3-hour kinds of meetings. But if we were able to keep it, closer to the school day, I think our school nurses are pretty invested now. I think they are enjoying it. I think they are enjoying working with the kids and seeing that benefit. So I think this is more coming from our relationship with the school, and that would be time that they would donate towards being involved with us. So I'm hoping that's what would happen.
That's great. Thank you for sharing. Any other questions for Tricia? Thank you so much, Tricia.
Thank you for inviting me.
Okay, now we're going to shift gears a little bit, and we have our Oregon immunization programs here. It wouldn't be a coordinators meeting if we didn't have an IMMYs update. So Erin is here, and we'll pass it over to Erin.
Hi, everybody. So this is just going to be a really quick update on some changes and possibly some new requirements or new information for y'all about VFC. So 2017, so we get new guidance from the CDC about VFC regulations every year, and so the 2017 changes have to do with first making sure that you're using the most updated temperature logs. This actually had to do with a sort of a rounding error when translating Fahrenheit and Celsius. So the correct range is 36 to 46 Fahrenheit. So Celsius hasn't changed. It was Fahrenheit that had the rounding error. So if you're using a log, if you use a Fahrenheit log and you're using one with the old range, please update that. We have samples available on our provider resources website. So just go ahead and if you don't have that bookmarked, just Google Oregon VFC provider resources and bookmark that. It has all the information that you need about everything about storage and handling and other tools. The other thing is a new required training. So you know that we've had the 3 online training modules around vaccine preparation, storage, handling, and administration. Those are required every other year by clinic staff, but there's a new one that's required by your primary VFC contact and that person's backup every year. And that is basically an overview of the VFC program. So it's kind of fun if you have questions about whether or not you sort of know everything about VFC that you need to know. You could take that quiz and test yourself. And that's on our training page under the heading Required VFC Vaccine Management Training. And it doesn't take that long. It took seems like years to develop it, but it takes less than an hour to do. There's a couple quizzes. So that's the 2017 information. Looking ahead towards 2018, because I guess we like to keep you guys looking ahead as much as we can. Beginning in January, so we'll have new requirements then. CDC has let us know that those requirements are going to include that you have to have thermometers that are digital data loggers, that have an active temperature display visible from outside the unit, so you can read the temperature without opening the door, and have a buffered temperature probe. So that's the probe is in like a little bottle with glycol or glass beads or something in it, so not an ambient air temperature for your main thermometer. And then be able to display a minimum and maximum temperature since the logger was last checked. So that means a big change in the way that you're actually doing your temp recordings. You're going to be recording once a day the minimum and max as read on the thermometer. You're not going to check it first thing in the morning and then last thing before you go home. So again, this is for 2018. So for this year, keep doing it the way that you are. Download a good Fahrenheit temp range log. But starting next year, you'll have a little bit different workflow. And then we always like to point out the wording that CDC uses called strongly recommended, because we tend to see that that actually becomes a requirement in future years. So if you're looking to make an investment in, if you're needing to buy something new to meet the requirements, you might look for something that also includes those recommended features that I have on there. Like, it's always a good idea to have an alarm to help, know when temps have gone out of range. To be accurate, to have a low battery indicator, a lot of memory. I'm not sure how they came at the number of 4,000 readings, but that is what they say. You want it to be able to program it so that it can be set to record every 5 minutes. And then we have updated the thermometer guide on our website with all of this information. So that's the link. But if you had just did, like I said, Google VFC provider resources, if you don't know where that is, you'll be able to find it. Okay. Now moving away from storage and handling, I'm sure that you all are probably aware of this, but just to remind you that there has been new guidelines released around HPV, that it can be a 2-dose schedule. It has to do with when you initiate immunizations. So if you've started the series before they turn 15, then it's a 2-dose schedule. And the second dose is 6 to 12 months after the first one. If they initiate it later than 15, or you don't make that 6 to 12 month window for the second dose, then it is still a standard 3-dose series like it is now. And alert is updated with that information, so it should be forecasting correctly for you based on that combination of patient's age and interval between the doses. And I'm happy to take questions at the end. I know that you guys are maybe on mute, and you'll just type in your questions if you have questions for me. So moving on to reporting non-viable vaccine. We have joined the 21st century. You no longer have to print out and fax us a form. We put an online survey form for you to report non-viable vaccine. So that should be a lot faster for you. It has a lot more instructions and a lot more options in terms of how you get your label. You could get it emailed to you, for example, rather than your provider of record. You don't have to wait for it to come via the U.S. Postal Service. So just a reminder, we want to know about all non-viable vaccine, and that includes vaccine that you're not going to return. Anything more than 1 dose basically should be reported using that survey, and it'll tell you how to get your label and how to clean up your inventory in alert as well. And the last little item is, hopefully people know about this, but because we've tried to publicize it as much as possible, we have a VFC help desk now. And so there's an email for them, which is vfc.help@state.or.us, or 971-673 for VFC, and that's 4832. And that should be staffed 9 to 4 every day. You should be able to get a live person unless they've stepped away from their desk. And also, unless it's something like a massive windstorm across Oregon where we're dealing with 30 temperature excursions in one day, which is what happened on Friday. You know, then it kind of takes us a while to get back to you. But in general, if you don't know who to call, if you don't already have someone that you call, that's the way to go. We're sort of moving away from that health educator map that you might have been used to and towards, because they're out of the office a lot, right? So we have a help desk that you can call and they'll get you in touch with somebody who's actually in the office. And that is all I've got.
We have a couple of questions already.
The
first question is, why is there not a combined fridge freezer for Fahrenheit?
I don't know. That's a good question. I can make a note that somebody would like a combined fridge freezer for Fahrenheit. So you've got a lab grade combo unit and you'd like to just use one log for both?
Sheena, yes, that's what she's very fast. That's what she wants. And then she actually has another question. Is there a way for the VFC coordinator to check and see if wasted vaccine was documented in SurveyMonkey?
Oh, for them to check whether it's been documented. So in other words,
so, yeah.
to see if you have already requested a return label.
Yeah, like if they filled it out already.
There isn't, because the way I set it up, it has to allow you to retake the survey, because otherwise, you know how SurveyMonkey, if you go to it and then it says you've already taken this survey, well then you'd only be able to report vaccine once a year. So best bet, call the VFC help desk and ask for that information. The email option of return label should happen as soon as Shelby has a chance to actually enter that. So if you haven't gotten if you ask for an email and you haven't gotten it within, say, 2 days, I would call, because there's probably a problem.
Great. Does anybody else have questions? Okay.
Great. Thank you, Erin.
Oh, wait. It looks like. Oh, a comment, not a question. Specified. I had a positive experience using the VFC help desk when we had our ice storm with the power outage. She left a message and someone emailed her back with all the information she needed, so she wants to thank you for that.
Well, that's great. Thanks for the feedback. We really appreciate it. It's been kind of some growing pains, you know, getting new people used to their roles and stuff, but we hope that it's helpful so that, you know, as we've transitioned more to having compliance specialists as well as health educators, that you guys have an easier time with getting a hold of us. So I'll pass that compliment on to Jennifer, who's usually the voice of your help desk.
Great. Thank you, Erin. Quick update, but really important information.
Okay. Good. I'm glad. Thanks for inviting us. We're always happy to come.
Great. And our final presenters today are the Oregon School-Based Health Alliance. And so, Lori, we're going to unmute you.
Hi, everyone. Can you hear me?
Great. Yes.
Great.
So,
well, good afternoon. We can move to the next slide. Just, again, a brief review of who we are. OSBHA, the Oregon School-Based Health Alliance, is a statewide nonprofit, and our mission is to strengthen school-based health services and systems that promote the health and academic success of young people. And the guiding principles for our work are, number one, sustaining, strengthening, and expanding school-based centers, health centers. Number two, promoting diversity and equity that engages the community and youth voice. And three, advocating for and facilitating integration of health, wellness, and education. And our staff include myself, Maureen Hinman, our policy director, Megan Kovacs, our program manager, and Jessica Chambers, our administrative coordinator. And both Maureen and Megan are with me today on the slideshow.
Hi, everyone. Hello. So this is Maureen. I'm going to talk about some of the legislative stuff really quickly. So our bill is House Bill 2408, and it has three components.
One is we've asked for funding for new planning grants for school-based health centers. The second component is we've asked for additional funding for the school-based mental health, and that would include funding that would go to the Oregon Health Authority for both school-based health centers and then also to put mental health providers directly into schools. Next slide. And then the third piece is to continue the trauma-informed schools pilots, which is 2 high schools that began this year, and extend that for another 2 years, which was the intent of the pilot in the first place. Next slide, please. So we had our hearing in the House Health Committee on March 24th. We had some people come and testify. We had a student from Portland Public. We had the behavioral health specialist from Milwaukee SBHC. We had some people from Reynolds School District who is looking to get a new school-based health centers, and someone from the Oregon Latino Health Coalition, in addition to myself. And so we had a very strong group of people, and I really appreciate those of you who helped organize the testimony. Legislators loved us. And so I fully anticipate that the bill will be referred to Ways and Means. They have what is called their work session tomorrow, which is where they actually vote on if the bill is going to move on. So I expect it to move on, and then at that point, in Ways and Means is where they will probably take quite a while, probably a couple months, to sort everything, sort through all the bills that require funding, and determine if there's enough money to fund them. So stay tuned for that. I think the positive news is, you know, there's not a lot of funding for new programs, but the fact that our bill was so completely supported and well received by legislators means that it's highly unlikely that our budget would be cut. So hoping for new funding, but at the very least, really feel fairly confident that our budget will not be cut. So I'm going to let Megan talk about Awareness Day for a bit.
Thanks. So we hosted our annual School-Based Health Center Legislative Awareness Day on February 27th. Thank you all for those of you who were able to make it. I think it was a really successful and exciting event, and it was a really effective event for building relationships with legislators all across the state. We had approximately 150 youth from 6 different counties, and they met with 30 representatives. Representative Rob Nose from Southeast Portland, who also happens to be my representative, spoke on the House floor while wearing a cape, like the true superhero of health that he is, acknowledged that February was Oregon School-Based Healthcare Awareness Month. We handed out capes to lots of folks during Awareness Day, but I think he was maybe the only one who wore his on the floor.
Yeah, I think so.
Next slide. These are some pictures. I believe that these are some of the Youth Action Council members from Centennial and some Portland Public folks meeting with House Speaker Tina Kotek. The next slide. And this is a group of the youth, some of them wearing their capes, in front of the state capitol. We were so glad to be able to host so many young people and to teach them about advocacy and policy, and to you know, help them share their perspective and share their ideas with their representatives.
Okay, so as always, we're a team. We consider ourselves a team with you all, as this is a membership organization, and so we really appreciate when you help advocate by coming to Awareness Day or doing things like, Tricia, I really appreciate that you had your legislator come out and see one of the centers. That's such a great way to really
demonstrate what SBHCs do in your communities. It makes a huge impact. And then also, we really appreciate hearing stories. If there are stories of students that have been impacted or parents that have expressed appreciation for the work that you've done, or stories that have really impacted you, then we would love to hear them. I sometimes use them when I testify they're anonymous, but I like to be able to tell real stories about how the SBHCs really work in real life. And then the other thing is we'll be sending out action alerts. So probably when our bill gets to Ways and Means and there's going to be a hearing there on it, we will probably send out an action alert asking for you to write letters of testimony and things like that to the people on the committee so that they can hear that there's a large community of people that really value school-based health centers. So this is Megan. On May 5th, we're going to be partnering with the Attorney General's Sexual Assault Task Force and hosting a training on improving medical care for trans patients. This was an identified need that came out of the Mental Health Summit. There was a short training on care for trans youth in that training, and one of the recommendations from in that summit, and one of the recommendations from the summit was, and one of the requests from folks was overwhelmingly more information and more training on working with trans youth and trans patients. The Attorney General Sexual Assault Task Force developed a training to work with sexual assault nurse examiners, and we are adapting that training for school-based health center staff. This is not a training that is purely or only for providers. Anyone who works within the school-based health center is welcome to come. There will be some background information on working with trans people, talking about pronouns, lots and lots of pieces that I think could be really valuable and beneficial to the entire community. There is a link to registration on the Sexual Assault Task Force's website, and this training is completely free for school-based health center staff, and we will be providing some travel funding if necessary. Just let me know. I sent out an email a few weeks ago. I'll send out a reminder email tomorrow for everyone so that you have the link to register. But please register. We're excited about it. And then also in May, May is an exciting month for us. If you happen to be in the Portland area, we're going to be hosting a really fun event to highlight some of our youth work, to announce our new core grantees, and it's happening at the Lagunitas Community Room. So there will be food, there will be beer, there will be live music. There will also be an a cappella performance from a youth group. So it's going to be a really fun night. It's on Thursday, May 25th from 6 to 9 in Northeast Portland. We'll send out information about that soon.
And this is Lori, just a brief update on the SBHC Advisory Committee that we're putting together. We are still moving forward, want to recruit 1 or 2 more persons who represent the non-Portland metro area. I think that we'll be able to confirm those people within the next 2 weeks, and then we'll give an update during the next meeting, coordinators meeting. And feel free to contact us at any point. Usually email is best, and we're all listed here. We'd love to hear from you. Thanks for this opportunity. Any questions?
If you have any questions, you can feel free to type them into the chat box.
Doesn't look like we have any.
Okay. So no questions at this time. And so the contact information is there for the Alliance, and thank you, Lori, Maureen, and Megan for presenting all that great information.
Thank you.
So just before we close, or our final closing, we will be having an October coordinators meeting, The dates and the logistics of what that's going to look like is to be determined. So we'll probably pull the field again on trying to figure out the best dates. So historically, in the past, every year except for last year, we have it during the day before the Teacher in-Service Day in October, and that always seemed to work well in the past when the Alliance was holding kind of a bigger conference. Last year, we partnered with the Reproductive Health Program to do a larger summit combining 2 days with when we had some additional funding. This year, depending on the funding and depending on the time that works for everyone, we'll figure out what that's going to look like. So just be on a lookout for more information that'll come out about that. So we don't have a date yet, but we will be communicating that with people because I know you need to get on your calendars for the travel. Any other closing questions? Give it about 5 seconds. Oh. Great. So remember that everything will get posted on our website in the next week, and if you have any questions about anything that came up today, you don't know who to contact, you can just contact the SBHC program, and we will get back to you. Thanks, everyone.
Thank you.